and my disclosure. There's nothing to disclose related to the work I do, but let me tell you there are a few disclosures. I'm an interventional cardiologist, so I'm biased towards Dr. Jaswinder. My center does about 3,000 procedures, and I personally do 1,000 procedures every year, and minimum 10% CTO PCIs. So that's what I used to be biased to. We got Japonified quite early, so we did a reasonable number of these procedures. And also at the same time, let me tell you, despite all the adversity of the cost, because the CTO PCI in India cost about 2 to 3 times more than routine PCI in CABG. So we were working against the cost factor as well. But this is a paradoxical situation which I am in right now. And let me tell you, I'm converted as far as CTO PCI is concerned. And compared to US, as you can see, we have 95 million CAD patients. PCI is done to about very small number, about 1% of them. And CTO PCI is 4% of our PCI numbers in India. And 97% are antegrade, 3% are retrograde. But let me now take you to the real facts. The CTO means worse CV outcomes and increased mortality. CTO is not benign, as everybody thinks. It is only less than 10% have normal coronary flows. It has low success, high complication rates. However, in the open PCI registry, the success went up to 86%. But let us look at this. Those people who believe in this, they think, and as you saw the data, that it improves patient symptoms, it improves quality of life, improves left ventricular ejection fraction, and probably it improves survival. But the scientific evidence supporting this treatment strategy is very, very minimal. Now look at this. When we do PCIs, what happens to us? We become more radiant because we get more radiation. And the fluoro time is generally 200 minutes. The procedure time is 4 to 5 hours. Contrast volume is generally 500 ml, so really hitting the kidneys all the time. And the stent length, as you also saw in the previous cases, is usually long, nearly 90 millimeters. And with this, we create more disease. And the failure rates are high because complications are high, retrograde approach is difficult, success rate is low, and the peri-procedural MIs are also a reality which we have to understand. We think that probably doing CTO is not a problem. Full metal jacket is also a risk. So look at this. We have no difference in terms of MACE, although death rates are slightly lesser in CTO successful patients, but complication rates go up. And these complication rates go up because we are attempting CTOs in difficult situations. Higher the JCTO scores, the higher the complication rates. So the success rate goes to as low as 50 to 60%. Now looking at peri-procedural MIs is also a huge problem, and the predictors of them are renal dysfunction, acute coronary syndrome, long stent lengths, number of stents used, retrograde approach, and double coronary injections. Everybody thought that once you open the artery, put as many stents as you want, but look at this data shows that the full metal jacket is a real bad thing which you do to the patients. It increases the TLF, and it increases the target lesion revascularization. Then look at this registry which came from San Medical Center, shows that the success rate is, and the successful and the failed patients, there is no difference. Both the patients do equally same way as it happens over the period of 4 years. Data again showing from the Credo registry, the Kyoto registry, showing that there is no difference in the successful CTO PCI patients and the failed CTO PCI patients. Then what is the point in doing these procedures in such a high degree of radiation and so much of contrast? The optimal medical therapy versus PCI data, which you see here, again shows that there is no difference in cardiac death-free survival. So all this is registry data. People will say, okay, let's look at the randomized controlled trials. He already mentioned, and in the morning also, about the 3 important trials which have been done, and they were stopped also in between. The Explore CTO trial showed that no improvement in ejection fraction in patients at 4 months, and in those patients, as you can see here, that the benefit of CTO PCI was not demonstrated at all. In the Decision CTO trial, the second trial, again showing that the 3-year MACE in the Decision CTO trial was 20% in the CTO group and 19.6% in the optimal medical therapy group, which means that over a period of time, you don't see any outcome differences when compared to just optimal medical therapy. Going to another third randomized trial, which is the EuroCTO trial, which did show some improvement in quality of life, but again, did not show any improvement of LV ejection fraction, improvement of cardiac mortality, or even MACE rates. So if you conclude the results of these randomized trials, the data does not show sufficient evidence for the routine use of CTO PCI in patients who have CTOs, and probably we'll need more randomized trials to really establish the role of CTO PCI, and it should only be limited to large centers and in expert hands, maybe in some patients. So the guidelines, as of now, it is still remaining in 2AB, and in 2017, from the AUC criteria, again, it is based on symptoms only, anti-anginal medication usage, and risk of ischemia. So what is the indication of CTO PCI as of today? To relieve angina, the data is limited. For prolongation of life, again, it is conjectural because it does not decrease the arrhythmic burden. It does not decrease large infarcts or events. So finally, it is a red light. It is a red signal due to lack of evidence from randomized controlled trials. Routine use of CTO PCI is not recommended. But in patients who have ischemia, symptoms despite optimal medical therapy, one can go ahead in large ischemic burdens, but still, there is a yellow signal showing that an informed decision-making, emphasizing risk and benefits, is the key for appropriate usage of CTO PCI. Thank you very much.